Hi there, everybody. Welcome back to breast cancer. Today we're going to be talking about treatment options. So like many other sites, we have different modalities that we are going to be exploring. So surgery, radiation, chemo. There's also going to be hormone manipulation and targeted therapies. So surgery, there's a few different options for types of surgery we could have depending on our stage grade and what the goals for that particular patient are. So we always want to start by being conservative. So in terms of breast conserving surgeries, these are when we're only going to take a portion of the breast. So lumpectomy, that is going to be the removal of the tumor with a margin of normal appearing tissue. So we do want to make sure that we have clear margins like we would for others. So this is going to be after our patient is actually diagnosed with a lump. So we have excluded or we have ruled out that this is going to be cystic. So now we can still take through this lumpectomy and do a test on it like a biopsy, but this is where we're actually going to remove the entire volume with that normal margin. Segmental resection is when it's a little bit bigger. So that's when we're going to remove the tumor, the surrounding tissues, and a lining of that chest muscle below the tumor site. So this is still a fairly large resection, but it is not a complete resection. Lumpectomy is much more specific. You're going to have just that scar where they've gone in and taken out that tissue, but for the most part, the breast will remain intact. If the patient is further advanced, then conservative surgeries are no longer an option. Now we're going to get into a mastectomy. So mastectomy is when we're going to take the entire breast. We have a few different options though, radical mastectomy and modified radical mastectomy. Radical means we're going to remove that entire breast as well as the axillary lymph node and pectoralis major. Modified is going to be much nicer. It's still a very extensive surgery, but this tends to be where we try and go for most of our patients. This is going to be removal of the breast tissue, the nipple areola, most of the axillary nodes, and the fascia over the pectoralis muscle. This keeps that pec major intact, and it results in less cosmetic and functional deformality. So our patients do much better afterwards as a result of this. So the other thing we need to keep in mind is that anytime we are looking at lymph nodes, lymphedema is a major issue. So especially with the radical mastectomies, modified radical mastectomy, there's going to be less of a risk, but it is still quite a substantial surgery. So we really need to be aware of what lymphedema is, how we're going to coach our patients, and that we are always looking for it. So we're going to learn a little bit more about lymphedema, and in some of your other courses, you're going to be pulling in a fair bit of lymphedema as well. So do keep that in mind. It's a very important concept for us to support our patients. Now, what's nice though is that even though breast conserving surgery is always preferred, a lot of the studies have actually demonstrated that conservative surgery followed by radiation is equivalent actually to a mastectomy in the treatment of early stage breast cancer. So that does give us some foundation to always be conservative when we're making recommendations, and then we can layer on different modalities to still achieve the best result and result in the best quality of life for our patients afterwards. Now, some of the indications for surgery, and this is going to be versus a lumpectomy. First is patient preference. There's still a lot of people that even though our evidence suggests that it is fairly equivalent actually in terms of overall survival and outcomes, there is a large majority of patients who just want the breast removed. They don't want to take any chances. They are not interested in going through all of these different things. So they would prefer just to have a mastectomy and call it a day. There's also a lot of patients who would prefer to have bilateral mastectomy and just call it a day. So we do really want to make sure that we're able to coach them through and be able to compare and contrast discussed all the different options in relation to where they are and to help support the patient, not only to feel good about their decision, but also to ensure that it is the most evidence-based and best for them. So modified medical restectomy is usually recommended when we don't think we can have free margins. So if we expect that the tumor volume is going to be invasive of a large amount of tissue, then it's probably not going to be beneficial. So something like a large tumor in a small breast, that would be a very common example. Also, if you're not able to have multimodal treatment, so if you're not able to have radiotherapy, then lumpectomy is inferior, and we do need to be very thoughtful about that. So things like if a patient is pregnant, if they've had previous radiation to the breast, so something potentially like a previous breast or like a lung or a lymphoma, some of those we do need to be thoughtful about the dose that that patient's actually received. If they have physical disabilities or cognitive disabilities, both of those can be challenging. So physical meaning laying flat, abducting your arm, being able to be in that position. Sometimes due ability to actually commit to appointments. So sometimes patients are transient. They don't have the ability to come in for all of those days. So if they're homeless, if they don't have support, if they have addiction issues or life issues, which is really the case for any site, but definitely something that we can then recommend in this particular situation, that a modified mastectomy is actually going to be better indicated for these types of patients. So always something that we do for all patients, but especially in this particular position when we do have options that are quite equivalent, some of the factors that are going to go into those decision-making strategies as well. So now part of surgery is going to be exploring lymph nodes. So there's a few different options for lymph nodes, and this is actually very important in helping to determine the stage of the cancer, and it acts as a prognostic factor. So lymph nodes, again, if we have the option, we're always going to choose a more conservative approach. So a more conservative approach for breast cancer would be a sentinel lymph node biopsy. So what that is we actually take a blue dye and we inject it behind the nipple. And what that does is that blue dye then travels through the different nodal pathways. The first lymph node in its path is the one that we consider the sentinel node. So keep in mind behind the nipple, in a very close proximity to that tumor bed. So that first node that the blue dye hits is considered that first node in the chain, the sentinel node. So what we do is we actually sample that node and we send it to the lab so it can be explored by pathology. If that node comes back and it is clean, there is no disease, then most of the time we will not progress to a full nodal dissection because there's not a need. That first node and those first few nodes, they are going to be indicative of what the rest of the chain is actually going to look like. So this is really important because, like we said, that lymphedema is a huge issue in terms of quality of life for these patients. And if we need to do a full axillary node dissection, that is a huge challenge for patients going forward. They are looking at physical therapy for quite a long time. They are looking at pain, discomfort, lack of mobility, and lymphedema really incorporates every part of your life. So you don't want to have needles in the arm that you had your dissection because your risk of having that lymph node blockage and that inability for the lymph to actually travel is so impeded, and it gets stuck and it creates almost like an elephantitis. So like you may have heard with legs is the other area that is quite susceptible to lymphedema, but the swelling is really, really substantial and painful, and it impacts everything. So even things like hangnails, if a hangnail gets infected, that can create a severe lymphedema. lymphedema. You don't want to carry anything heavy because any type of pressure in that hand or any type of weight bearing can really have a negative impact for these patients. And so we always want to keep that in mind. So traditionally as well is what we would do is we would actually, if those nodes came back positive, we would progress a patient and do an axillary node dissection. So that way we really knew what we were working with. Radiation therapy has come quite a long way. And now what we tend to do is if they do come back with a node positive in the sentinel node chain, then what we do is we actually don't progress them to an axillary node dissection. We will upstage them in essence, and so that way they will get treated with radiation through their entire nodal chains. We will assume that they are advanced, and because we have the ability now with imaging and with the quality of our rads, we can actually treat them quite effectively, and we'll save them that lymphedema, that range of motion, that pain, all of those complications from that node dissection. So that's kind of nice in terms of how we have evolved to be able to better care for our patients. So early stage breast cancer is considered to be less than 5 centimeters, no more than 3 nodes, and it usually consists of stage 1 and up to 2A. And then locally advanced is greater than 5, involving more than 3 nodes with potential spread. So this one can go from 2B up to 3C. There's also inflammatory breast cancer that can actually be composed of any cell type. It's usually stage 4, but it's a minimum of stage 3B. So we spoke a little bit about that one. That's where it has involved the skin and it looks almost infection-like. It is very aggressive and it has distinct clinical features. It generally accounts for less than 1% of breast cancer, and that's where you're going to see that pot orange, that erythema, that warm thickening, that diffuse induration, that skin, those dermal lymphatic involvements, and it usually has a prognosis of about 2 years, so it is very fast growing and extremely aggressive. So that is one that you will definitely want to be aware of. DCIS, ductal carcinoma in situ, is early, that's precancerous. Inflammatory is extremely negative. It is very progressive and a very poor prognosis. Metastatic disease, just like any others, is where we've actually spread to other parts of the body. Okay, so here is some stages with your different grades and how they are broken down. So stage 0 is any TIS, so any tumor in situ, so either ductal or lobular carcinoma in situ. So that is disease without any nodal or lymphatic involvement. That's generally a precancerous. Stage 1 is going to be any tumor that's 2 centimeters or less. This also includes T1 mix, so microinvasion, not larger than 0.1 centimeters in greatest diameter. You have your stage 2 there, stage 3, no more than 5 centimeters, and stage 4 includes direct extension to your chest wall or your skin. So for radiation therapy, we've talked a little bit about this in its role alongside conservative surgery. It is very good at eradicating subclinical disease after surgery. So it does improve that local regional control and reduces recurrence, which then in turn improves long-term survival. So in early stage, generally you're going to have some type of surgery, usually a breast conserving surgery. So remove that tumor with a margin of normal tissue. And then like we said, auxiliary node assessment will be done in either of these situations, usually with that sentinel node biopsy. So I should also note that when you see, and you will see your breast patients on the floor, and they will have a blue, it looks almost like a bruise, but it's more bluish, and it's usually offset of the nipple, a little bit behind the nipple. That's what you will then recognize as being that sentinel node biopsy. So then the adjuvant treatment, so after you've had your surgery, most often we will include radiation therapy of some type, and that is going to attempt to control any type of residual disease and therefore reduce the cancer risk and long-term survival. So like we said, early stage breast cancer in women who have had mastectomy versus women who have had lumpectomy and post-RT actually have the same outcomes, which is wonderful news. We also will include for a large portion of the population some type of systemic therapies, so either chemotherapy, endocrine therapy, or targeted therapy. So DCIS, ductal carcinoma in situ, post-segmental resection, so again after a conservative surgery. We do still want to assess if they would benefit from radiation therapy. So this is going to reduce their local failure rate because we do anticipate, even though it is precancerous, that it does have the potential to progress. So we always want to assess to make sure that we are giving them all of the treatment that we can to improve their overall survival. So that 2/3 is fairly substantial, so we need to be aware of that. Adding radiation doesn't necessarily indicate an overall survival advantage. Just because DCIS is still very early, it's not necessarily invasive yet, but it does reduce local failure. So for patients that will actually be beneficial, that they won't progress to a cancer, which then needs to be treated with a little bit more definition. So that's all that means. Post-mastectomy, if you are going to have a mastectomy, for virtually all patients, generally there's no need to include radiation therapy. The exception being that if there is still gross positive surgical margins, so if the disease was fairly spread out, if they were not confident that they were able to remove all of the disease with that normal tissue, that's when we're still going to add in radiation therapy to be able to ensure that we can sterilize that whole tumor bed and that chest wall. So if the patient has invasive disease and they are going to have a post-segmental resection, this is the one where it is disease. They are going to have radiation therapy with an advantage. So we are going to improve overall survival by about 5% because it does reduce local failure. It also, that resection, that conservative surgery maintains cosmesis and that quality of life. So all of those psychosocial issues for that patient. So keep in mind, locally advanced breast cancer, larger tumors greater than 5 centimeters, and then post-mastectomy, so they will require radiation if they are advanced, so if they have positive lymph nodes, if they have those positive surgical margins, that's when we are going to treat with radiation any areas of high-risk recurrence, so chest wall, regional lymphatic, so dermal, axillary, inframammary, supraclavicular nodes would all be examples. And again, this does improve local survival, about 5 to 10% increase if you have node positive disease. All right, thank you very much for your time. We will talk again soon.